Hey everybody, it's Dr. Cameron Dennis. Let's do the bonus lesson. So this is Module 3. This is the last part of Module 3, the last presentation for Module 3 of the knee pain solution. So we're going to be talking about Achilles tendonitis or Achilles tendinopathy. Okay, so I do realize that this is not necessarily a knee problem, but seeing as how the gastrocnemius attaches to the femur. It's sort of part of the knee. This is a really common injury, so I wanted to make sure that I included it in the presentation. So what and where? So as you can see here on the left, that's the lateral head of, so this will be, actually, is that right? I didn't make this, so bear with me, but that looks like they have that backwards. It's hard to tell which side this is, but to me, this looks like the right foot, which would make the medial and lateral head labels backwards. So like I said, I just found this online. I didn't realize this. But anyway, hard to kind of tell from this angle, but it's not that important. So the soleus runs underneath the gastrocnemius muscles. Muscle, I should say. There's two heads of it, but it's one muscle. Runs underneath the Achilles tendon and then attaches to the Achilles tendon down a little lower there. So the Achilles tendon attaches from the gastroc down to the calcaneus in the heel, which is like your heel bone. So what happens with Achilles tendonitis or Achilles tendinopathy? So as mentioned in another video, with tendonitis or tendinopathy, we're not 100% sure what's going on. So that means treatment for this injury changes all the time as more research is performed. So it was that they did a lot of cross-friction massage, a lot of ultrasound, a lot of heat, things like that, but more and more science is coming out to say that we need to involve more loading of that tissue and more exercise, and to really take a good look at our training. Okay. So the reason I put that slide in there is because if we're looking at this 5 years after it was made, this may be completely different. But this is our best understanding of how treatment and how this process works for Achilles tendinopathy, and it's ever changing, just like everything else in the health field. So keep that in mind when watching. But if you've gotten this in 2018, this is the most up-to-date information that I have. So this is not an inflammatory process, which is why they got rid of the tendonitis, the itis part of tendonitis, which refers to inflammation, and have renamed it tendinopathy. Okay. So the acute process is tendinopathy. The chronic is known as tendinosis, which is just like a condition of the tendon, more a long-term chronic issue. So the tendon may become swollen in a small area. However, it is not due to inflammation. It's due to an increase in water within the tissue itself. It can become tender in that area as well. So this means it does not typically respond to ultrasound, height, heat, ice, to reduce inflammation, because there is no inflammation, no measurable inflammation as far as we know. It may reduce pain in other ways through blocking pain signals or manipulating the nervous system, but it does not reduce inflammation. So interesting to know. So what's the difference between the different stages? Because there are different stages of tendinopathy. So there's what we refer to as reactive tendon. There's also tendons in a disrepair, which is sort of in between reactive and degenerative, but we'll just kind of stick with these two. These are kind of the different extremes, right? So reactive tendon is going to be usually a short-term or an acute stage due to an increase in activity or lack of rest and recovery. It could be due to a single activity done on one day that just led to excessive load being put on that tendon itself and reducing or leading to the aggravation or irritation of that structure. So there's no structural change. There's not necessarily any damage to the tendon at this point. It's just reactive, what we call it, reactive. It's irritated, it's sensitive. So a degenerative tendon, usually a chronic injury caused by long-term insult to the tendon through training or repetitive excessive load. So this is something, if your tendon has been reactive for a long period of time, left untreated, it can turn degenerative, which is actually damaged tendon. So not necessarily the whole tendon, but there are certainly fibers which may be damaged. So leads to thickening and potentially even having nodules on the tendon, building up of scar tissue, the lack of the tendon's ability to actually perform as intended. So usually you see degenerative tendons in older athletes, but it can be present in younger athletes if reactive tendon is left untreated. So what to do in the reactive stage, which, like I said, is the more acute stage. Typically more pain is associated with the reactive stage. So reduce load on the tendon. Avoid stretching. Avoid excessive weightlifting such as calf raises, squats. Allow it to rest. In some instances, it may be worth wearing a boot for a week or two just to take the excessive load, take the weight off of that tendon and allow it to heal, allow it to settle down a little bit. So it may only take a few days to a week to have significant reduction in pain. So that's good news. And that would, you could have that without any actual damage to the tendon. So if you act quickly enough. So may slowly add strength training and walk to run training once pain is reduced and tendon is out of the reactive stage. So important. You may not know how the tendon will respond to the exercise during the exercise because it takes somewhere around 24 hours or more for tendons to respond and to react to that load. So modify your exercise program accordingly. So after you've waited about 24 hours, if you feel like maybe you did a little too much, that pain is above a 5 or 6 out of 10, when it maybe was a 2 or a 3, maybe you need to do a little less next time you go into the gym. So what to do in a degenerative stage? So start slowly with isometric exercise, such as calf isometrics on a step. So we'll go over this in Module 4. I'll demonstrate it, but stand on the first step facing the steps. Stand on the edge of the step with only the front half of your foot on the step and hold your foot parallel to the ground. So you'll do this with both feet. And then as you get stronger, you may do that with one foot. Maybe a little bit painful for you to do it, or you may be a little bit weak to do it with just the one foot at first, but you can progress to that as you get stronger, right? I suggest doing this every day or at least every other day. So you may progress to this with single leg after a few sessions and with good tolerance to this activity. So progress to heel raises on the ground after this. So not on the step. You're not dipping below neutral. You're just going from the ground to doing a heel raise. You can hold it a few seconds. There's nothing wrong with that. So may add weight slowly as tolerated. Hip and knee strengthening may be performed as well. So keep in mind the tendon is made of many fibers. Part of the tendon may be in reactive phase, while another is in degenerative phase. So say the tendon is made up of 100 fibers, which is made up of way more than that. But if it was, 30% may be in the reactive phase, 70% may be in the degenerative phase, or vice versa. It's just an example. But basically just know that you can actually have part of the tendon being in one phase and part of it being in another. So in this situation, I would recommend that you just pretend like the entire tendon is in the reactive phase, allow it to rest and come out of that reactive phase, because you really don't want to be putting excessive loads on a tendon in the reactive phase. It'll just cause it to get worse. So doing too much too soon can actually result in tendon rupture. So be careful and progress slowly. When in doubt, get it checked out. Okay, I didn't make that up, but it's a good saying. So if you attempt to rest the tendon, but the pain does not appear to be improving in regards to pain, see a PT for evaluation. If you do not feel comfortable with the progressions, doing them on your own or progressing yourself, please see a PT for evaluation or reach out to a trusted source for guidance, whether that be myself or someone in our company with Back on Track Therapy, or with someone who referred you to this program. Just ask any of those people for assistance. Okay, so like I said, there's a lot of debate about what to do with runners with Achilles tendinopathy. So this is the most up-to-date information that I have. It's by no means the gold standard. There is really no gold standard at this point. However, this is what I've seen to help in my clinic, and this is what recommendations are from those who know the research and the literature well. So this is the sort of the understanding that I have of it. So hopefully that makes sense. Hopefully you got a lot out of this module. It took a lot of work putting together, but I will see you guys in module 4. Thank you.